particular in the field of liver transplantation. So again, a disclosure, this is nothing to do with personal choice. I have picked these papers from how they've been cited, which journals they've been published, if they have made an impact, according to me, on clinical practice, and in the future will make an impact on clinical practice. So rather than putting it as surgery, hepatology, and anesthesia, I thought of putting it as which were the topics most written about in liver transplantation in 21-22. So that would give us a fair idea about what is important and what everyone is talking about these days. So number one is cardiovascular complications in liver transplant recipients. Now this was a score, it's called as a CAD-LT score, effectively predicts risk of significant coronary artery disease in liver transplant candidates. It was called as the CAD-LT score. So their aim was to predict the risk of significant CAD in LT candidates and guide pre-LT cardiac evaluation. Huge cohort, 1,700 patients at the Indiana University. Definition of significant CAD were those requiring percutaneous or surgical intervention, either before or during the waiting period for transplantation. And they found that risk-adjusted predictors of significant CAD at cardiac catheterization were older age, male sex, diabetes, hypertension, tobacco use, family history of CAD, and personal history of CAD. So they stratified CAD risk as low risk, which was up to 2%, intermediate 3 to 9%, and high risk more than 10%. And they said that if you have actually a low risk, if you use the CAD-LT score, you would have identified 97% of significant CAD. And those with low risk actually would not have required a cath. Those with intermediate would have required non-invasive testing only. And those with high definitely would require a cath prior to transplant. So basically today we see that everyone probably, there is because of the high risk that happens and coronary events that happen post-transplant, many of them go detailed or in depth to investigate these patients, which essentially is not wrong. But then this tried to stratify that and say that who should be investigated in depth and who may not be at a high risk. So I think significant paper, especially in terms of the anesthesia guys who look at this very carefully before they clear a patient for surgery. The second aspect, cirrhotic cardiomyopathy. Now, all these papers have come up basically because we are seeing cardiac complications post-transplant, and we lose recipients post-transplant because of cardiac complications, nothing to do actually with the liver. So this was about cirrhotic cardiomyopathy. This, again, it came from a center in the US where they evaluated the prevalence of CCM according to a new classification. It's the CCC 2020 classification. And look at the criteria here. And these are something that we should think about. Diastolic dysfunction, left ventricular ejection fraction up to 50%, or GLS. And this is very important that all anesthesiologists as well as cardiologists look at now if you have an absolute value of less than 18. So these were the criteria for cirrhotic cardiomyopathy. It was a single center retrospective MASH cohort study. This is the percentage of CCM, and they found that patients with CCM obviously had increased risk of post-LT cardiovascular events. And changes in CCM individual parameters pre-LT with increased risk for post-LT CVD were GLS, early diastolic transmitral flow to early diastolic mitral annular velocity, and a left atrial volume index. So this provided a validation, and CCM was higher in NASH patients. So this is another important thing that came out of the study. An editorial which spoke about this particular paper said that what was one of the drawbacks was that none of the CCM patients had a resting systolic dysfunction below the diagnostic threshold of LVEF less than 50%. So this was considered to be one of the drawbacks of this particular study. And this actually was addressed by a study from India. This is from Medanta. And they looked at 12 patients. 6 of them had CAD, 6 of them had CCM, and the EF ranged from 25 to 45%. During LDLT, 2 patients developed ventricular ectopic rhythm. Stress cardiomyopathy manifested in 3 patients. 2 of them improved while 1 needed IABP also post-op. And you look at those 5-year survival, 75%, 66%. But what conclusion they reached at was that those with stable CAD and good performance status and well-optimized CCM patients may be considered, but they need to be risk stratified and they should be handled in experience centers. And this was an algorithm that was proposed as to how you should evaluate these particular patients with ECG, DSE, and a coronary calcium score. And then if DSE is inconclusive, you go to a stress thallium or an angiography. And then risk factors were coronary artery calcium score of more than 100 and other risk factors which are well known like diabetes, hypertension. So they were also considered. So this was an algorithm that was proposed in that paper. Second, although not very common in India, but we are going to get there. DCD, preservation and machine perfusion, and these are the hot topics for last 2 years. So this was the HOPE study, the HOPE ECD DBD study. So this was a large study that it was a randomized control trial. They look at 23 patients with HOPE versus 23 patients with the standard normal preservation. And they definitely showed that HOPE had a 47% decrease in serum peak transaminases, a significant reduction in 90-day complications. Trend towards reduced EAD was observed with HOPE in these particular patients in the ECD patients. And finally, this, of course, was recognized as the best paper, Vanguard paper by the IITS this year. So again, role of hypothermic machine perfusion. This was another randomized control trial, again, an important trial. It was called as the DHOPE DCD trial, investigator trial. And again, they showed that in these patients, the incidence in these DCD livers with HOPE was much, much lower of all the complications. And obviously, even the treatment required for non-anastomotic strictures was much less. So another important study on hypothermic machine perfusion here. This study was a futuristic type of study. They tried to look at what can you define as a global benchmark for donation after circulatory death liver transplantation. And I think he was a very dear friend, Paolo Musan, whom we lost last year. He was an executive council member of ILTS. He was the senior author and he drove this particular thing. This was the first attempt at benchmarking as to when can you accept a patient after circulatory death to get good results. And I think I'll not go into the details, but those who are interested should read this. I think this is a very good diagram as to tell you, or it's a small algorithm as to tell you where you should draw the line, which are the patients that you should, which are the donors that you should accept in order to get these particular results and get good results which are acceptable. So you can expand and you can actually go ahead with DCD. There were some drawbacks. They didn't consider transaminases pre-intra-procurement or degree of steatosis for exclusion, but nevertheless, it provides a reference level of performance regarding DCD-LT using basic procurement and storage techniques. This is another very nice paper on Ischemic Colangiopathy, and why I liked it was basically they defined that when you get these particular features post-operatively on an MRCP, what are the chances that this patient is going to require retransplant, whereas patients who will recover without a retransplant. So they classified these into A, which was normal MRCP, B and C. These are the patients who definitely will require a retransplant. They're not going to improve with whatever stenting you do, whatever bypass you do. And these are ones which will not require a need for retransplantation. So these are all strictures which are the type of ischemic cholangiopathy inserts that developed after extended criteria DCD or DBD or DCD donations. And this was a very nice representation of how we can make out which are those which will improve and which are those which will not improve. Obviously, this was the year of SARS-CoV-2. And lots of papers coming out of this. This was one of the first papers, what is relevant to us, severe cholestatic hepatitis secondary to SARS-CoV-2. These were two initial reports that came in, and it actually defined what happens in these patients. How do you see the trend of SAP, AST, as well as ALT, and how it changes, and how serum bilirubin peaks from 5 to 29. Very good demonstration that on liver biopsy, which was done on day 14, they showed only cholestatic hepatitis. And you see the MRCP changes. Actually, there are no MRCP changes at all. So on day 11, normal hepatic changes, even MRCP on day 95, just mild hepatic steatosis, no biliary pathology seen. So basically, it's a histological diagnosis. You get cholestatic hepatitis, but it improves with time. Next, what about those who are infected with SARS-CoV-2 after liver transplantation? And these were two large databases that were created, the Secure Liver and the COVID HEP international databases. And they actually found that, demonstrated that the potential for COVID-19 infection among patients with CLD-LT recipients who had received COVID-19 vaccination, the chances of them developing severe disease was much less. And therefore, they said you should go ahead and vaccinate as compared to not vaccinating. But then there were controversies that there are unwanted effects also of mRNA vaccines, and you will see that there is reports of autoimmune hepatitis developing after coronavirus disease 19 vaccine. First report of post-transplant autoimmune hepatitis recurrence also, so de novo as well as recurrence, and even allograft rejection after using the SARS-CoV-2. This was with the Pfizer-BioNTech. But again, I want to stress on the fact that these were just a few of the complications that were there, but the benefit is much larger than these particular few complications were there. So there should not be in any way any discouraging word to say that we should not vaccinate these patients. Next, in patients, they also showed that in patients who come to you post-transplant with COVID-19 positive, the use of these early would help in limiting the severity of the disease. So this was a very nice study which showed that if you use these particular drugs, the monoclonal antibodies therapies, early outpatient intervention reduced the patient's death after transplant. So that was about COVID. And this was a very significant paper that came out. And look at the heading of this paper, title of this paper. Liver transplantation using hepatitis C virus viremic donors into hepatitis C virus A viremic recipients, and they call it standard of care. That means you put in an HCV RNA positive into an HCV RNA negative, and they're calling it standard of care today. So this is a huge change from when we used to not accept HCV liver at all for non-HCV patients. And again, I'll not go into details, but you'll see here that the overall survival as well as the graft survival was similar in between patients who were hepatitis C virus positive. But there were some caveats here. What they said was that you should have verified DAA access. There should be no critical drug-drug interactions with DDIs, with DAAs. And there should be an informed consent, and DNAT positive organs were offered to waitlisted patients irrespective of their recipient HCV status. So you should be sure that in the post-transplant period, you're going to be able to treat them with good DAAs, with efficacious DAAs, and then you can use these particular grafts. This is DDLT, of course, this is not LDLT. This was an editorial on the same thing and basically challenged the concept of standard of care so early. And it showed the evolution from when we never used to use, and then ribavirin came in, and then DAAs came in, and now we are talking of standard of care using HCV positive into HCV negative. Next, I think this is an emerging field, expanding the indications for liver transplant in cancer. We are probably going to discuss this in the second half of this meeting. And liver transplant oncology, which is a new concept, emerging concept. So this was the Spanish Society consensus conference where they looked at how you could expand recipient age, or you can go beyond recipient age, how you can expand transplantation for HCC, for acute alcoholic hepatitis, for ACLF, for unresectable hilar cholangiocarcinoma, intrahepatic cholangiocarcinoma in patients with liver cirrhosis, as well as liver metastasis from colorectal cancer. And they recommended for unresectable hilar cholangio that if you could follow the Mayo Clinic protocol, then probably you should go ahead with these particular patients because they have a surplus of DDLT livers available, disease donor livers available as well. And intrahepatic cholangiocarcinoma still only for tumors which are less than 2 centimeters, but you could think of good results in patients with intrahepatic cholangios less than 2 centimeters in size, though they are very difficult to detect at that particular time. Now that was early intrahepatic cholangio. This is for advanced intrahepatic cholangio, and this was a huge study that was done from Houston, which looked at tumors which were more than 2 centimeters, sometimes even 10 and 12 centimeters in size, where they used the neoadjuvant therapy, first line being gemcitabine cisplatin, followed by radiotherapy, and then they could transplant these patients, and they could still achieve survivals of about 50% at 5 years. If you look at the graph on the right side, that's the patient survival, and recurrence-free survival of about 52% at 3 years. So early days, but they are looking at this now with great intent. But yes, highly selected group of patients. The patient population and pre-LT strategies were heterogeneous, and the small study size obviously limits, and we need more studies for this. This was an important consensus conference that ILTS did, and we looked here at what we should aim as the minimum recipient survival at 5 years if you're expanding indications for HCC or for tumors. And we agreed upon a 60% survival at 5 years. And we said that we could expand criteria, especially in the LDLT setting, if you were to consider tumor biology. And I think that's the consequence of a lot of studies that have been done in Asia, especially from Asian countries. This is BCLC 2022, and you look at the first time now in intermediate stage HCC, transplant comes in, which was never there before. It was only TACE and sorafenib. This is the first time that now you're considering alpha-fetoprotein, you're considering extended criteria based on size and number, and you're considering them for transplant after downstaging. So this, I think, is an important change that has occurred in the entire attitude. Looking at portal vein tumor thrombosis, one of the first results that came in about radioembolization to downstage these patients and then transplant them. This is from the DDLT setting, and they showed a clear survival gain in those patients who were able to be downstaged, and they did receive a DDLT after TARE, but careful selection, they said, was required. The problem with this study was that if you actually look at it, they looked at it as intention to treat. And if you were to look at this was from Bologna, and this is the editorial based on that. So 3 out of the 5 patients actually who reached transplant recurred after transplant, and that was very early, 1 to 2 years, within 1 to 2 years. And then 15 out of 17 patients in this study, they failed actually what was called a super downstaging protocol. So initial attempts, but not great results out of it. But then we showed this in the LDLT setting and published this last year. So again, 25 patients with VP1, VP2, VP3, and 1 patient with VP4 portal vein tumor thrombosis who were downstage by using a combination of SBRT plus TARE. And we were able to achieve 53% 5-year survival and 52% recurrence-free survival in them. 25 patients. We are now at around 40 patients, and we are doing this. Again, we have found that VP4 is a bad prognostic factor. It's very good if you use segmental, use it in segmental, that is VP1, VP2, you can get good results in the long term. This was a very interesting paper, and this is something that people have been talking about, that you can use statins in the post-operative period to reduce the recurrence of hepatocellular carcinoma. So they said that the anti-cancer effect of statins was consistently significant across even multivariate, stratified, and sensitivity analysis. And the graphs look very stunning. They look very, looks as if we have conquered something. But here I also thought we should point out papers which do have a potential weakness. So it was a single center retrospective analysis. The median time between LT and commencing the statin was close to 3 years. And most of the recurrences we know happen in the first 1 or 2 years. And it's difficult to comprehend how statin use led to this impressive reduction in this incidence of all-cause mortality with an astounding 20% improved survival. So sometimes when you read something, you should also be able to know what's right and what's wrong. And I don't think that this really showed us too much. Another aspect that I think is very important. Now we are in a stage where we are seeing long-term patients after transplant. We are now seeing patients who have had transplants 15 years, 20 years back. We are seeing patients who have had, many centers are seeing patients who have had transplants 10 years back. So now you will start seeing these problems. You will start seeing long-term issues. One of them is post-transplant malignancy. Look at this, non-hepatic causes of death beyond 1 year post-transplant. 30% of them are because of de novo malignancy. So this is something that was addressed in this last year's consensus conference of ILTS along with the Spanish Transplant Society. And this was the evidence that came out of it. Calcineurin inhibitors should be universally reduced as much as possible in these patients. Mycophenolate and mTOR inhibitors do not seem to increase the risk of de novo cancer. And even after recurrence, there was some evidence to show that mTOR inhibitors would improve survival, and conversion to everolimus was associated with survival even after the recurrence of cancer. So we should now look at this also very carefully in our patients who come for long-term follow-up. We should look at de novo malignancies because this is a reality. We may not see the skin cancers or the non-melanoma skin cancers in the West, but then we see head, face, neck cancers very commonly. We see bladder cancers commonly, and we should keep a close watch out on these cancers. Finally, I'll go to machine learning, artificial intelligence. This is the present, probably going to be the recent future. This was a score actually which was developed based on artificial intelligence. This was the MELD 3.0 score. One of the main problems is that which was identified was sex disparity when you give organs. So women had a very low chance of actually getting organs when they are placed on a waiting list in the DDLT setting. So they did find that if you were to do this, this was based again, as I said, on machine learning algorithms, and it correctly reclassified a net of 8.8% of descendants to a higher MELD tire, and therefore they could get access to transplantation. And it was found that particularly this was true in the case of women. So that sex disparity that was there, they tried to correct it. It was there even in the MELD sodium score, because usually the MELD sodium score in females, even as compared to their disease, is lower, and therefore they don't get priority in countries where MELD is followed. This was another score on, again, machine learning, HCC, a machine learning approach, is the Toronto post-liver transplant hepatocellular carcinoma score. And again, I won't go into the details, but good to look at this. This is a calculator which is available online also, which you can use to calculate what is the chance that it can recur. And it's important to validate this, however, in outside cohorts, and that is happening. I know that they are already validating this outside. This was another type of papers, like the static paper. Preoperative CT scan helps to predict outcome of the liver transplantation for ACLF grade 3. And they found that multivariate analysis, ECT-derived prognostic factors were found: splenomegaly, liver atrophy, and vena cava diameter ratio. And they said based on this, you could actually develop a prognostic score. Interesting paper to read. I think everyone should read it and see what they get out of this particular score. But CTs are done in all patients before transplant. And then if you could look at simple parameters like this and get out some information at least in terms of prognosis, then why not? I want to finish with some Indian papers that I think stood out this last 21-22. This was a paper that came as a part of the APASL ACLF working group. That first week is the crucial period for deciding living donor liver transplantation in patients with ACLF. A large cohort of patients, more than 1,000 patients who looked at this. And you see very nicely depicted here that in the early period, if you see in day 0, many of them are not fit for transplant because they have got multiple issues. You're trying to stabilize their kidneys, you're trying to stabilize their lungs, they have hepatic encephalopathy. Then towards day 4-5, you have about 63% of them who are actually transplantable. You can transplant them. As you go towards day 7, it becomes 61%. Beyond that, then that drastically reduces to about 20%, 30%. So if you want to get good results in these particular patients, probably you need to stabilize them and take that decision within the first 7 days. That's what comes out of this paper in order to transplant them. If you wait too long, you're going to lose the opportunity to transplant them. This was with relationship to living donor liver transplantation. This came from Apollo Group. A new parameter to predict graft-related outcomes in adult living donor liver transplantation. It was called as the HPI. It was hyperperfusion-related graft injury index, or the hyperperfusion index. And here they use total pressure gradient and graft recipient spheric volume ratio. It was devised on basis of flow of dynamics, etc. And they found that on multivariate analysis, these actually predicted early allograft dysfunction. The good thing to look at, I think, is something, because when we talk about low GRWR grafts and total pressure hemodynamics, I think this is something that could be looked at. This, of course, comes from Kochi, randomized clinical trial of MHV reconstruction of cryopreserved versus Ptfe grafts. And again, showed that there was no difference. The important thing about this trial, is that about 5-6 years back, at an international conference, Busutil said, again, you talk about metalytic pain, I'm going to vomit out. But everyone used to say my technique is better, cryopreserved is better, someone used to say Ptfe is better, someone used to say Dacron is better. But this trial actually showed by randomizing that it makes no difference. So you should do what is comfortable, what you think you get good results with. This was a paper from Dr. Subhash Gupta's group from Max. Sometimes you land up in trouble when you do a living donor hepatectomy and you cut more on the left as compared to the right. You get a closed narrow stump, which is shown in this particular diagram very nicely. And here he showed that you could use the cystic duct well vascularized stump to actually put a patch on that particular thing. You could get very good outflow with this. So it's a salvage technique for us surgeons who have made a mistake. And I have used it in one case. And we have had, he's absolutely doing well about a year. We didn't know what else we could do. Otherwise, the only option is to do a root, which is very, very, it's morbid. So nice depiction about how this can be done. So worth reading. Again, I think should be, I should call it a landmark paper, because this is now, we are showing the way to the world, probably having such a large series in a short period of time. Again, from Dr. Sudhindran's group, large number of robotic right donor hepatectomies were performed with extended criteria, and they showed that the results were not bad, they were as good. This paper comes from our institute, and the reason I want to show you this paper is now this concept of incorporating tumor biology when you're selecting patients for transplant. So we had a total of 400 patients, 49% of them were outside Milan, and we had 43% outside UCSF criteria. We calculated and we developed a competing risk regression model by which we could classify these patients into low risk, moderate risk, and high risk groups. And the difference in the recurrence, 9%, 25%, and 46%. And then we proposed an algorithm that, based upon the three prognostic factors, alpha fetoprotein, UCSF, and FTG18 PET ability, if none of these are positive, alpha fetoprotein more than 100, beyond UCSF criteria, or FTG18 PET habit, they are considered low risk. You can go for upfront transplant. If 2 out of these 3 are positive, moderate risk, ideally you should downstage these patients before you transplant to get better results. And if they are high risk, then definitely there's no role of transplant unless you actually convert them into low risk, and then you can transplant them. So I'm going to finish with that. I'll just finish with this. When you go up there and you say, can you please check why my name is not there to go into heaven? So you finally, if you don't publish, you perish. So they ask you that, you publish or perish, check me in the publish or perish category. And he didn't publish, so he perished is what comes up there. And this is the evolution of academia, I think. Initially, everyone used to say publish. At least you should publish. Then they said that if you don't publish, you will perish. Then they said, now you have to publish only in high impact journals or you will perish. Then it came to publish frequently in high impact journals. Maybe you won't perish. If you don't publish, definitely you're going to perish. And then it comes to high impact journals frequently. But I think that should not be a mad rush to publish, because then you'll come up with papers like statins, which actually are of no worth. Just keep calm, work properly, and write on. So I just like to finish with that. Thank you so much.
So, how often do you find cardiovascular problems is post-operative mortality and cardiac MIs?
So I think there are 2-3 things. I think the incidence of cirrhotic cardiomyopathy is quite high. It's about 5 to 10% when you look at post-operatively what has an effect on the patient recovery. Most of these patients will recover. Out of the 5 to 10% who will have these complications of cirrhotic cardiomyopathy, they'll go into stress cardiomyopathy post-op. About 5% of them will improve with medical treatment. About 2% of them have problems which actually lead to problems with the graft as well, because you're going to have hypotension, you're going to have problems with the general hemodynamics, and then you're going to be in trouble. 1 to 2% of these people actually will even require IABPs and intra-aortic balloon pressures. So cardiomyopathy, cirrhotic cardiomyopathy, I think is an issue, especially in alcoholic patients. And now there is recent evidence to show that in NASH patients also, the incidence of cardiomyopathy is high. As far as MI is concerned, I think, as you rightly said, the incidence is low. But having said that, just last week we had a patient on post-operative day 3 with S segment changes with very high and cardiac enzymes level and a straightforward MI, and we didn't know what to do. We just went on general normal management. You cannot, stent them. You cannot do a PTCA. We just went on. The cardiologist said, go ahead with normal. You cannot thrombolize them. So when it does happen, it's a big problem. So I think it's important to evaluate them preoperatively, because with a 10% incidence, I think anything that causes a 10% incidence is quite a high incidence in the post-operative period as far as cardiac is concerned. So looking at it from the cardiology point of view as well as the anesthesiology point of view, I think is important in these patients, especially NASH and alcoholic patients.
Yeah, thank you, Prashanth. Extremely useful, and listening to you, we realized that I should stop. I think regarding as Vincent's point about the cardiovascular risk, I do agree that sometimes if we follow the guidelines that are recommended for non-cirrhotic patients, we end up doing much more interventions for our patients. I mean, practically, we don't have a huge experience. I can't quote literature, but we've seen that a lot of times we end up disobeying our cardiologist and we go against them and still take up these patients for certain patients who they've said that these patients require a CAH. But most times, we have managed to do it. So I think we need to be not, the kind of literature that talks about, just a calcium score you see and straight away Russian food and straight away you realize. I just wanted some clarification about your HCC patients. I think you are the group who really advocated the pre-op mediation on taking these patients. But if I'm quoting you wrong, you said 40 patients. You guys have been doing it for a long time. I mean, is it just 40 patients or is it 40 patients? And how do you think things have evolved? Because we have seen kind of mixed results. Sometimes you really can't really predict which patients are going to do it.
So 25 patients is what we published. At present, we are at 40. There are caveats in this. If you start off with 100 patients, you will be able to reach downstaging and transplanting 50. So it's a 50% result. The reason why you would go with SBRT and tear in these patients is not doing that. There is hardly any option for them. So if they are fit to start off as compared to just systemic therapy, using SBRT in them or tear in them, provided their liver function allows that, because you need a bilirubin of less than 3.5 if you want to do any of those, at least gives them the chance of prolonging the survival, which has been shown in several studies, from say 4 months to 5 months with sorafenib to about 8 months, 9 months, 10 months, 11 months with combination radiotherapy, whether it's SBRT, tear. Out of those patients with whom you start with an intention to treat, as I said, 50% of them will not go to transplant. In 50% of them, you will have to look at risk factors. You will have to look whether there is a complete eradication of the portal vein tumor thrombus. That means there has to be complete loss of enhancement. There has to be loss of FDG18 avidity. The disease has to be stable outside the liver. That means there should be no occurrence of any extrahepatic metastasis during that period. And an adequate period of at least 2 to 3 months after having done the radiotherapy and seeing the response. If you break any of these criteria, you're going to have bad results. So I think there are lots of things that have to go in finally to get those patients who will have good results. But the whole concept, like you're asking, why do you want to do things in them, is basically because actually you're left with nothing. If you don't do anything for them, their survival is going to be 2 months. So you start out. If you're successful, you can go ahead to transplant, but you have to follow certain strict principles in choosing these patients. And we are at the infancy. I'll be very clear. I think we still don't know too much about this, but then at least you're giving them a ray of hope, which was never there before.
Any online questions? I think we have online audience or anyone in the live audience. I love your last slide, because now there are so many journals out there. Getting a journal published is so difficult. And they don't accept. Previously, a randomized trial included thesis.
Yeah.
Now it's so difficult.
And you look at the impact factors of these journals.
Always we start lying.
So I'll just give you a simple example of that. I'm one of the associate editors of Transplantation now, Transplantation Journal. There was a paper that was sent for review by a center from Korea, Samsung, which center, more than 100 patients retransplanted using LDLT. Results were 50%. 50% survival, 50% died. It is everyone's results. It's your results also, it's my results also. When you transplant, 50% will die. I tried my best to push this paper. Everyone said bad results, we can't publish it.
95% survival.
What does it mean? You have to publish what is the truth. This is the truth. You have to publish it. If you don't publish it, people will not know. It's not because you're a bad center. You don't know how to do a retransplant. It's just that the results are like that. So what you're saying is absolutely right. I think that unless and until you actually publish the truth and try to publish the truth, and journals don't take that. So I think you can go to the next one.
Should we go to the next one? And for the next session, we have the panel discussion. I think very important topic for participants. The moderator is going to be Dr. Karthik. Dr. Karthik is a senior consultant in the transplant research. Welcome to Kochi. Thank you. And the panelists are Dr. Ptfe, who is the lead at the hospital in Kochi. And Dr. Matthew Jacob, who is the lead liver transplant surgeon at the hospital. And Dr. Ramchandran, who is the lead transplant surgeon at the hospital. Yeah. So Ramchandra is not Mr. Prashanth is going to make his speech.
Sharing. Is the presentation? It's not open. Which is it? This one? Can you just help him share this? Share this.
Can you just, voice can you just announce that there can be online sessions? They can just contact us. No, at the end of time, a lot of people online, they won't have any doubt, they can send the questions. Stop.
I welcome all the panelists. So we're going to discuss about transplant oncology scenario in HCC. See, in liver, HCC is always an ever-evolving field. A lot of changes, a lot of research has been happening worldwide. And for people who are online, you can always post your questions on the chat box. So at the end of the presentation, probably will address all the questions. So we will talk about one interesting case of HCC, which I think patient was from Kerala only. So there was in Jan 2021, a 50-year-old gentleman presented with CLD, child CA, with multicentric HCC, and he had right portal vein tumor thrombus. And the lesion was infiltrative in nature, 9.3 into 5.2 into 6.7 centimeter in segment 7 and 8. And the right portal vein tumor thrombus went all the way up to the intrahepatic branches. The left portal vein, main portal vein, and hepatic veins were free of thrombus. A PET scan was done. There was no evidence of any extrahepatic spread. And alpha fetoprotein was 43,125. And the patient had a very good performance status and the child's A. So what will you do for this patient, sir? What's next? So what will be an intended management approach? Whether will you choose a palliative or will you attempt to downstage it? And at this stage, how aggressive can one be even to think of, transplanting this patient in the future?
Okay. Just get everything started. So it's not an uncommon scenario. I'm sure we all see similar patients pretty much on a daily basis. And the reality is that a small proportion, it's only going to be a small proportion that we ever get to a curative stage. But I think the point which we are discussing during the last topic is relevant here, that we should not rule anybody out. There's a 50-year-old chap who's got 43,000 AFP and an advanced treatment last year in thrombosis. I think the issue is to whether we give him an aggressive treatment with a curative intent to see whether we can get into downstage. That would be my approach. So the intelligent management approach would be to try and get in downstage to a situation where we can hope to get into the curative treatment if we get to transplantation. So the initial approach would be curative, not panic.
Any other opinions from the audience or the panelists? We all agree with that?
So I think that to start off, I think this is a very difficult question. What right portal vein tumor thrombus, which has gone right to the intraobatic branch, is a 43,000 AFP level and it's multiple. So all in all, it is a patient who most likely has got a very bad prognosis. You will think of doing something for him, and I agree with you that you try to do whatever is best fit. Now, in that, you will start off probably in the back of your mind, you think that this is palliative. But you will try to do whatever you can. And then there are other concerns that come in. Number one, is any sort of therapy possible or not? You said that it's a child-safe patient. So yes, probably I would think of some sort of concurrent therapy, systemic plus local ablation. In this case, probably it would be a TARE, radioembolization, based upon the bilirubin, based upon the shunting, all that will have to be looked at initially, along with a combined systemic therapy, and see how things go. Maybe 1 month down the line or 2 months down the line. The second thing is that I think thinking of transplant at this stage is a distant thought. So it's too difficult to think of transplant at this particular stage, and we should not go against biology or against this thing, which is very bad in this particular patient. But try whatever you can do best in this particular patient with whatever is.
Okay, to summarize, 50-year-old man with AFP of 40,000 range and a large tumor infiltrative nature with right intrahepatic portal vein tumor thrombus as well. So we all agree that we need to be aggressive, and since age is aside, good performance status, we'll do the best to see how he responds. Because usually in these kind of multimodal therapy, we won't know how each and every patient is going to respond to it, because the biological nature of tumor itself is quite different. Until date, we don't have an exact mechanism to find out how these biological markers are and how they behave. So we don't have one particular marker to say, yes, this is aggressive, don't treat it. But every year there are quite a lot of biological markers that are coming up. And finally, there is no conclusion, there is no standard of gold standard saying, okay, this particular biological marker is very good in predicting. So with this, the patient, this also has been addressed. So downstaging is standard again now. So tumor lesion, we have to address the tumor lesion here, either with stays or TARE. And in India, sometimes TARE is not available in a lot of institutes because we need to have a radionuclear setup and license to carry out TARE. And right portal vein tumor thrombus by an SBRT. And apart from these two, any other new modalities? Chemo, immunotherapy?
Yeah, sorry, Doctor, just before we get to treating, I just want to ask for perhaps Study and Sherry and others who have a bit more experience. What about biopsy as part of the workup for this particular group of patients? We know that we have got a bad disease presentation to help select out in deciding how to be aggressive. I know that biopsy for all sorts of reasons, but now we are talking more and more about biopsy, at least for this select group of patients. My colleagues also.
What are we looking at in a biopsy?
So the bad things which are going to predict
an aggressive behavior, for example, differentiation, the type of HCC, we have to pick up microvascular patient or other biomarkers which are still in the nascent stage, etc. But and maybe the odd diagnosis of a hepatic colangiopathy, we are basing all of this on imaging. So if you've got an advanced tumor, and if they have additional bad prognosis on biopsy as well, then perhaps I won't be as enthusiastic in putting him through all those aggressive treatments.
So you're saying that if he shows poor biological markers or anything, you won't be very aggressive in doing taste, tear, or SPRT or whatever it is.
Well, it helps in and I'm guiding the patient as well. Because all of these treatments have a cost implication, etc. So if it's got a poorly differentiated HCC with the type which is not the lymphocytic infiltrate, the aggressive one, then we can educate or give the patient the option, like, look, your biopsy markers are also bad. What do you want to do? At least we can have a bit more meaningful conversation with the patient in choosing this aggressive style of treatment.
I think it's more sensible to explain to the patient and ask for the consent, because some patients who can afford, they say like, I will go all out, do whatever it is possible. And some patients won't be able to afford, so they will back off. So I think it's a sensible thing to, discuss openly with the patient. And I think biopsy is not a bad idea. It's not for diagnosis here. It's to prognosticate the disease.
In this particular case, I'm not so sure, because the 2 or 3 important things that you're looking for example, macrovascular invasion is already there. Secondly, the high AFP suggests that it's a poor differentiation. Biologically, it's anyway. So in this particular case, I'm not so sure. But sometimes, in borderline cases with no vascular invasion, it never be bad. For example, multiple tumors, 10, 15 centimeter tumor. Otherwise, it's okay. It may be bad idea to get a biopsy and see this macrovascular. Yeah, from the heart, this sort of a patient, I confess that I've never managed to transplant somebody yet. But there's opportunities that exist, which is why probably this case is put up, I guess.
Can I make a point on that? So here you have an advanced tumor, and if you're planning for a systemic therapy, then biopsy might be useful there. So you can do a PD-L1 or you can. There are a lot of markers where PK can be used, where PD-L1 can be used. So then a lot of new markers that are coming in. So
yeah, this is PD-L1 like we're talking about. PD-L1.
There are a lot of markers that are coming from PD-L1 and the markers that denote that patient response to PKs. So such advanced cases, it might be always better to start biopsy.
So my personal opinion is that 5 years from now, I think people are going to use biopsy. We have so much of genomic data. The Roche that is providing Exosomes. Now they are offering free genomic, blood-based or tissue-based free genomics. And if you have an mTOR or something like that, usually it's a CCDA1 or PDL1. So PDL1 may benefit with atezolizumab. The tumor may regress, not probably this case, but so if you have an mTOR inhibition, you have an mTOR inhibitor. So I think we are just probably 5 years down the lane. In cases like this, biopsy is going to be and genomic studies are going to be in, and the risk of seeding might be too low. I think that's going to be the standard of care 5 years from now.
Yeah, I think, sir.
One more mic there, right? One more mic.
So you can.
I think the role of biopsy is something that I also believe that we are going back to what we used to be done before, and for various reasons that Charles also has cited. Again, I feel maybe not for this patient as of now, but if you look at the Toronto score, you look at the score for GAS score includes grade of tumor. So
if you look at their this thing, they would do a biopsy in everyone, find poorly differentiated, you would actually not go ahead with it. The issue with that in our setting is that what we have looked at in our 300 odd patients, the incidence of poorly differentiated HCC is only 8%. 92% of them are well differentiated or moderately differentiated. So to detect those 8% of patients, biopsy actually may not be useful. But this is for patients who do not have overt signs of very aggressive disease. Here you have an overt sign of aggressive disease, and yes, when those things do come in terms of markers and everything, yes, it may be useful. So we may be going back to biopsy, but I think in this particular patient, maybe not yet.
Anyway, this patient didn't get a biopsy done. And so he went elsewhere out of Kerala to get a taste done. It was done in 2021. And then he was put on sorafenib. And post-taste AFP in a couple of weeks dropped down to 39,000 and still not a great drop. Follow-up within a month's time, AFP shot up to 89,000. So what will you think now? So what's running in our mind?
Just one thing. Taste in such a big tumor is not a great idea. First of all, you're not going to achieve what you are setting out to achieve one session. You require multiple sessions of taste to treat this tumor. Second thing is that the post-embolization syndrome can be huge because they will have a huge amount of necrosis that will happen if the taste actually works. So in such a big tumor, I would not prefer a taste. I would do probably care. But now there is some inclination towards doing a combination of taste plus larger tumors. Multiple so TARE would have been my first option.
TARE, for some reason, TARE was not.
Maybe it was not available or the patient was not having that much money. Maybe patient fraction was high, that's why TARE could not be done.
Some other technical reasons.
I would like them to comment before we go to what should be done now. About this particular course, that immediate drop. First of all, just one comment from my side that post AFP, when you look at AFP for the younger guys as well, don't look at it less than 3 weeks after the taste, because that's the minimum half-life. Less than until 3 half-lives are achieved, you're not going to be able to see any more. So don't do it within 2 weeks of doing a taste of no relevance. This probably may be a temporary drop. Just short again. Consider second line systemic therapy in the form of Randomized or even immunotherapy, because we've seen that the combination of PD-L1 and VGF has shown even complete response in the range of 5.5. So one may have to consider systemic immunotherapy.
My thing is, ALP with the max time was doubled, 90,000. So will you still be aggressive in taking it further, or what will you say in a normal time to the patient? Because it's not a usual situation.
In this case, so we didn't receive the right treatment.
We started by saying that we would give the benefit of the doubt, although the background mind.
चोरी डकैती के यहाँ अखम चोरी डकैती नहीं करता है
You should treat it and see whether give the right treatment. The right treatment was what we discussed. To treat the disease as well as give systemic therapy.
So as clinicians, we still have not lost hope and will push the patient to go a little more aggressive. Try second line. We haven't addressed the PVTT as well. So why? Because you said some of us. Because we have seen in clinical practice, hepatologists or even oncologists. Because in India, still we don't get many HCC like oncologists see. Hepatologists or surgeons. It's still with them. Even all the PD1, PD-L1 trials, all with oncologists. The hepatologists are even part of it. Very sad. But a lot of them, they turn down. They say, go home.
यहाँ एक हर 10 किलोमीटर पर आना के दवा और एक हर 10
Even if he does reach a transplant, you treat him as Dr.Prashanth earlier pointed out. So putting on a Sarakrim selling you treat him.
जनरल देखिए आप गुड़गांव में गुड़गांव की एक्सप्रेस
can I
देने से पता है
reach a transplant.
एकदम पूरा रोड पे कवर करके आप बाहर
whether to continue further treatment or stop it here and send him back home.
रोड
That
को
was
पूरा
the
कवर
dilemma at this
Yeah, with the child cirrhosis promotes as
रोड
good.
को पूरा कवर करके एग्जिट देना
And definitely.
और यहाँ एग्जिट देखिए तो कोई तरफ में यहाँ एंट्री नहीं
So this patient
should
had a combination of locoregional and systemic therapy at the outset.
अब ये वाला कोई साथ हाँ
If you look at the BCLC 2022 also, the first line therapy in these patients actually today is Exosomes. Now you may think about whether it is going to be useful. You talk about the cost, which is absolutely prohibitive. We are not even thinking about cost. Absolutely prohibitive. But if not, if we are discussing medicine and if we are discussing evidence, then this patient ideally should be treated with locoregional plus systemic therapy. Locoregional would be TARE, systemic therapy would be Exosomes. And like Matthew said, he still not got what he actually deserves. Case was not the next choice. So he should be treated. And I think the next line of treatment is Exosomes.
So let's see the next line of treatment.
So FPRT would only address the portal vein tumor thrombus, number one. Second, the tumor is huge. It is a 9.3 centimeter tumor. So if you want to do one-step therapy for both, for the tumor and the portal vein tumor thrombus, TARE is a better option. When you combine TARE with SPRT, normally you look at TARE for lesion and SPRT for PVDT. SPRT has been shown to be useful till 5 centimeter tumors. Very large tumors, SPRT is not very useful. So if you give up to 50 Cgray of SPRT and you give TARE combined, if you have 60% of non-tumoral liver, it is safe. So it has to be fiducial placed directed SPRT along with TARE with at least 60% of non-tumoral. No, very sure it helped. Yes. Again, I think it had a lot to do with patient selection, like they're talking about PDL1, which of the receptors were there, nothing was studied. It was just put into TARE versus Soraka.
But even then, immunotherapy was not an option in that.
If we had enough residual liver volume and it is not infiltrated, and the residual functional liver is a bit more, then we would probably do SPRT first, address the PVT, then go and do a TACE. Probably since this is a large lesion, why the response did not happen was there might be a lot of necrosis within the tumor. When you have large amount of necrosis TACE, multi-session TACE only works. Single TACE really doesn't work if there is necrosis.
That's why Dr. Prashanth said TARE would have been the best option than TACE. But for various reasons here, I think for technical reasons, we're not able to. But and then after that, somebody switched him to lenvatinib. PVTT was not addressed, and then SBRT was planned 50 Gray over a week span of time. And then he was put on immunotherapy, PD-L1 inhibitor, atezolizumab, plus VEGF-A inhibitor. And he completed 3 cycles. I think there was one, I think recently the combination of PD-L1 inhibitor and VEGF, there are 2-3 papers also published on that. And it has supported that the combination therapy which addresses the aggressive vascularity of the tumor, especially in this tumor, probably since it was 9.3 centimeter infiltrated, it would have worked.
Okay, I think there is still evidence that is emerging. The MBRAVE trial, which is going on at present, final results, we just have preliminary results, which are again showing, going towards a positive thing. But if you look at the West, where insurance is paying for all this, they are hugely using Atezo and that's their first line now for anything that is beyond intermediate stage, even in intermediate stage. For us, it is hugely prohibitive. It is about 1 crore of rupees for one, if I'm not mistaken, 1 crore, 96 lakhs something.
No.
No, if you actually want to do the entire combination therapy, 1 lakh per month, right? So if you were to do a therapy of 3 cycles, how much would that actually cost if you were to buy it?
Anywhere from 4 to 7 lakhs. Different centers, 4 to 7 lakhs.
Patient paid 8 lakhs. I think this cost was 8 lakhs for 3 cycles.
We have a system that is generating.
So I guess
So it can be
is cheaper. 15,000.
For colorectal, nowadays a lot of institutes are using bevacizumab. It has become a standard of care, especially when it is primarily normal. So SBRT was done by end of March. So 30 grays over a span of 5 days. And then re-evaluation was done by using a whole body PET scan, and no evidence of any enhancing lesion in the liver as well as the right portal vein tumor thrombus. July 2021, the AFP dropped to 6.8. Maybe you should say the patient is lucky.
So you mean the portal vein is opened up? There's no tumor thrombus?
Tumor thrombus, bland thrombus was there, but it didn't light up. Previously, it was an enhancing tumor thrombus, but I mean, it didn't vanish. So this is it.
There's no tumor activity shown on PET, and there's this.
It was sterilized.
Yeah, it's reflected in the AFP as well. Yeah, so I'm still waiting to see whether he comes up with systemic disease elsewhere, whether it progresses elsewhere in the liver. How long we wait is another thing we can discuss.
So the test of time. So at this stage, can we discuss transplant as an option with the patient, because we're talking about a very practical scenario. So your patient comes to your OPD with this report and he asks, what's next, doctor?
To be honest,
So January we started, it's like 7 months.
I'm pretty sure the transplant has been discussed at the first instance itself. Because that's how.
No, first instance, I don't think so. It was discussed, it was on the table.
No, not here.
No, just
A practical situation.
okay.
By the time such a patient comes to a liver center, they will go to many centers and they come and ask us, I got this disease, and we consider transplant. So we are actually winding back from it. So we are trying to tone down their expectations. And we tell them that, yes, you have aggressive disease. Transplantation is a long way away. And then we have to temporize the expectations. We put them through all of this. We still have to tell them all the process. That's what I meant by the transplant discussion, or at least the ideal transplant will already be there in most patients. But whether we aggressively pursue it, start things, put it in place, I would say not yet. But they would have already been trying about the rare possibility of a transplant in the first instance, but whether by a transplant center or someone.
Dr. Ven?
It's true that it's the transplantation, not to wait at least 3 to 6 months to see if the tumor comes back, and then only discuss about the transplant.
So at this
way, whether to continue with immunotherapy or not discussed. Please.
So I think there's another aspect which comes in. Patients who have had atezolizumab, the chances of graft loss, if they are transplanted at least within 3 months, after the last dose of immunotherapy, chance of graft loss is huge. That has been shown. So one is about the PBTT aspect. The second is about the atezolizumab aspect. So from PBTT aspect, actually, if I had not given atezolizumab to this patient, if I had seen that for 3 to 4 months, there is no progression of disease after achieving a sterile portal vein tumor first, then probably I would go ahead with the transplant.
So if he has a living donor option and the PD-L1 inhibitor was not given, so you would say transplant at this stage.
So to clarify, I start with SBRT and TARE or whatever, or only SBRT. I watch the response at 4 to 6 weeks.
Okay.
See if the enhancement of the tumor thrombus has gone. After that, I wait for 3 months. In the intermediate 3 months, there should be no progression of disease. There should be no extrahepatic disease. there should be no re-enhancement of the portal vein tumor first. Only then I will go ahead.
How about the AFP?
Also look at the delta AFP. What was the AFP before, and whether the AFPs remain down and it's not going up again.
No significant jump in the AFP.
So that is then I would consider. Now this Aclf brings in a new angle. First of all, with the evidence available till now, I would never trust.
Because all the trials have showed that severe graft loss and severe rejection and a lot of necrosis has happened if it was done at an early stage. But now I think all the trials are, even though it's not again it's a gold standard, nobody has, there is no standard time limit, but everybody has assumed that 3 months, that is 12 to 14 weeks, certain centers have tried postponing the transplant. So follow-up advice for liver transplant, I think March 2022. So he was, since he didn't have a suitable living donor, so he was registered for a DDLT. So if he's been registered for DDLT, is it justified for him to give allocate an organ? I mean, it's just for our discussion. So, because we say that beyond UCSF we don't.
Within UCSF.
Yes. So I mean, is that clear to everybody? I mean, do we all agree with that? That since he's been down staged, so he still qualifies for a cadaver.
So downstaged and stable with not going off criteria for 6 months, yes, probably. You can transplant with the DDLT because this is what is being followed with the UNOS protocol, which is now in force. Whether it should be 6 months or 1 year is a different question. For such large tumors, probably it should be a year. We are a country which is not privileged with disease donor organs. So I think those rules also change depending upon where you are in the world. So you cannot offer a DDLT to a CRLF patient, whereas Norway can do right, left, center DDLTs for them. So I think that also differs. So in our scenario in India, I would still be skeptical. Anyway, he has no tumor as of now. Let's try with the miraculous Aclf person.
Okay, so the current status as of a couple of months back in April 2022, recent PET scan was done. So no metabolically active lesion, and again the right portal vein tumor thrombus remained sterile, and the AFP is bang normal, still 2.68 from 6 again it has showed a downward trend, and he has been listed in 2-3 centers for waiting for a cadaveric liver transplant. So again, the controversial topics, I mean, Dr. Prashanth also touched upon a few important articles which came out this year. Again, so now again, it's been very clear that even if it is multicentric, they still hold a chance for transplant if it is not gone beyond. And again, it comes to the ifs and buts, saying that the tumor biology, AFP, vascular invasion. And there's another scenario, what if both right and left portal vein are involved and NPV is free? Will we still do an aggressive SBRT?
Okay, so as Dr. Group has been quite aggressive and a lot of studies from Japan as well. So there is portal vein tumor thrombus and portal vein tumor thrombus. You talk about your V1s and V2s, V3s, and V4s. The ones you talk about main portal vein, you talk about V4 ones, which have got very bad outcome. And the chances of long-term survival in those with any aggressive treatment, whether it is resection or transplant, is anecdotal. So the ones which we can at least say with some confidence, I would still say some confidence, is only the V1s and V2s. It may be the V3s. So if the NPV is involved, then with the current, what we know, probably is out. At the confidence of what V3, again, that is depends on time of the day. They also have a poor prognosis compared to. So that is what my little bit to discuss.
Two classifications which are used for portal vein tumor thrombosis commonly. One is the Japanese classification, which is BP1, BP2, or BP1 is segmental, BP2 is sectoral, BP3 is right main portal vein, left portal vein, and BP4 would be main portal vein. The Chen's classification is the other classification, where Chen 1 and type 2, these are segmental portal vein tumor thrombosis. BP3 is not BP3, it's Chen type 3, is right portal vein or left portal vein. 4 is right and left portal vein and MPV square. And 5 is where you have MPV also, or it has gone beyond that. That studies also in that have shown that if you have bilateral or opposite side tumor thrombosis, outcome is worse. It's comparable to LPV. So to answer your second question is RPV, LPV, both of them have tumor thrombus. The outcome would be more and more similar to main portal. If only one of them have it, then the outcome is probably better as compared to a main portal. Again, if you have a tumor on one side and portal vein tumor thrombosis on the other side, that is another consideration that it is bad. Although usually you don't see it in contiguity. So I think for location wise, these are the things, but the good results are with segmental and with sectoral. So BP1, BP2, and some BP3 show good results.
So futuristic can change, right? The advent of immunotherapy and other things coming up.
I think so. As I said, it should be local plus system in any case. So our patients also, when we give them local TER plus SPRT, we keep them on that also with the sparing in between, because you have an intermediate period where you are waiting. Just like in colorectal liver metastasis, you give 2-3 cycles of chemotherapy in between the waiting period for portal vein embolization or when you do ALPS. So ALPS goes faster. But in this also, I think there has to be systemic therapy. If there is no systemic therapy, you are not going to get results.
So it's been very clear that no single modal therapy is going to help in any way. It always should be a combination. And the combination depends upon the patient's scenario. Right? If the patient doesn't have a portal vein tumor thrombosis, there's no SBRT needed. And size doesn't matter today.
Size does matter. Size does matter. More than 10 centimeter versus less than 10 centimeter is a huge difference. When you say multicentric, it depends upon what is the size of the multicentric. If you have 20 versus 10 tumors and they are 1 centimeter in size, it's hugely different from 10 tumors, one of which is 8 or 10 centimeters and the other are 1 centimeter. So size does matter. Size corroborates with microvascular invasion. Size corroborates with your alpha-fetoprotein PIVKA2 levels and microvascular invasion, which is again PIVKA2 corroborates with it. So size does matter. Larger size tumors are worse as compared to smaller size. Numbers probably small tumors too.
Doesn't matter. So, but see, there is another, it is not a hypothetical situation. So there was like a multiple tumor, 5-6 lesions. So both the lobes were involved and AFP was normal. No portal vein tumor thrombus elsewhere. And somebody has done a biopsy and biopsy did show well differentiated.
That's fine. I think differentiation of the tumor, grade of the tumor, and multicentricity probably don't go hand in hand. Because you have to remember HCC also is heterogeneous. In one you may get poorly differentiated, the other one may be well differentiated
Within the same
liver. So there is a difference in terms of, there is heterogeneity in the HCC as well. So I think that's why probably we are still not sure what we are aiming to get with our field. But we haven't found that tumor grade is important in our science.
So what will you do in case there's a local rupture of a large lesion? And is he still transplantable or is beyond that?
The patient is claiming embolization, otherwise palliative. Maybe immunotherapy can be tried, but we don't have the real evidence to support.
So I think there's all sorts of things, or at least a couple of things about rupture when it comes to HCC. One is a tumor bleed. The second is a tumor rupture, where you have direct tumor rupture and seedling into the peritoneum. In the interface, it's very difficult to differentiate between the two. The clinical presentation would determine what we do, and the good thing is to stop the bleeding with a taste for an embolization. Whether you would transplant, etc., those things are not for immediate. So these kind of patients would be approached in a similar philosophy as what we were discussing for the tumor complex patients. Don't rule them out. Treat them, treat the disease, stage the disease, treat the disease, and wait and watch and see how the tumor behaves, how the liver disease goes. And then once you've had an opportunity to treat them and observe them for maybe 3 months or 6 months, then reevaluate where you are. If it is a real tumor rupture, then you would, or they would present with metastatic disease.
So you will still give them a chance. So you are very aggressive, sir. I mean, all liver transplant surgeons are aggressive, but it's good to see somebody even very aggressive. So I think that's a valid point where we still give them a chance, reevaluate after 2-3 months to see any seedling is there elsewhere in the peritoneal disease or not. And once it's only a local and contained, probably we can still take them up for transplant. And what about a local invasion? Say if there is a segment 8 lesion and it's close to the diaphragm, or a segment 2-3 lesion stuck to the diaphragm. So will you do a local resection of the diaphragm, or will you consider it as a outside spread?
So there's a couple of different things you mentioned in one breath. One was lesion stuck to the diaphragm. Then there's about metastasis or what spread adjacent to the diaphragm. To me, both are different things. If you have metastasis adjacent to the tumor, which are not contiguous with the tumor that is being grown. On the other hand, if it is something which we say here, then proceed with resecting that part itself along with it.
So if the tumor is stuck to the diaphragm, then you will do a local resection of the diaphragm, right? But if the tumor is not stuck and you see a seedling in the diaphragm, then you straight away say. Any other thoughts?
So I would not be very keen if there is a large diaphragm. Usually these diaphragmatic attachments or contiguous spread to the diaphragm happen when you run a local ablation from that particular area. You run an RFA or MWA from that particular area, and you find that there is, and you're not sure whether it's actually tumor or whether there's an area of fibrosis where it has spread. So if it's a small area of contiguous involvement of the diaphragm, yes, I will do a section of the diaphragm and probably repair the diaphragm. But one thing is in all these patients, and definitely like Dr. Matthew said, if there's anything that is distant, typically you will see in these patients supra or subdiaphragmatic nodes which are there. We have published a paper also where our management has changed with endoscopic ultrasound. So in preoperative patients with lymph nodal disease, we see lymph nodes which are large in size. In order to rule out metastatic spread, even if they are not on FDG avid, and the tumor is FDG avid, if they are size wise more than 1 centimeter, you still do an EUS maintaining. That changed about 25% for management strategies. Something want to be tuberculosis, something want to be actually metastasis, not go ahead, and something want to be reactive, even though they were FDG independent.
That's interesting point, because even when I was in Medanta, we never used to do that EUS FNA. If it didn't light up, there was both petavid and node, we would definitely do it. But if the tumor is, I mean, the node is still, the tumor is petavid and the node is not petavid, but it's clinically significant, more than 1 centimeter, more than 0.8 millimeter.
And honestly, if you say homogeneous networking, you will suspect more that it's one you still go ahead and so these lymph nodes, if there is a subdiaphragmatic lymph node which is scenario where you find metastasis. Anything that is distant, non-contiguous, yes, I think it's a contraindication. Small involvement of the diaphragm, I can't say what is small. 1 centimeter, 2 centimeter, is probably resected along with that. Generally, a good biology.
So I have a patient currently who had a tumor rupture, and after tumor rupture, the diaphragm is under it.
This is probably 1+1. There is a human rupture. It's probably I just do it because of some problem.
So we'll turn it down. So in post-transplant options, so now since we are all talking about immunotherapy might be for the future, but how safe are immunotherapy post-transplant?
Totally unsafe. Graft loss more than 70% studies that have been shown. The Exosomes, nothing. So post-op, if you have recurrence, I think you're only left with 10%. Immunotherapy, whatever studies are there, it's
11 cases in the literature. All have used actually PD1 neolymph. And no publications regarding Exosomes was 6 months. And what has happened in our unit last year is in August, we did this combination and patient underwent transplant the first week of August last year. And now we're celebrating 1 year next month. So far, no rejection results. This patient actually underwent complex surgery in the form of ABO incompatible. So we received rituximab 3 weeks before transplant. Of course, it is stopped, I think, 6 weeks before. It's 27 weeks PR. So we stopped it 6 weeks before transplant. Then we got rituximab 3 sessions of plasma exchange and post-op little transaminase on day 6 and day 12. In 2 sessions of plasma exchange. And after that, no transaminase means elevation of enzymes is completely one. So that's
This post-transplant.
No. This Exosomes seems to more safe. Exosomes is the PDL1 inhibitor. So the action PDL2 will be served. Use PD1, both are blocked. So the rejection episodes will be less with this combination. So probably it is promising.
See, obviously you're talking about a post-transplant patient.
Post-transplant scenario, that's all. Yeah, post-transplant, say like, I mean, obviously HCV do recur at some point of time.
Because of adjuvant or
After recurrence.
So this is to treat the recurrence you're talking about.
Yeah.
So there's a review in Nature. It's an excellent paper. It addresses exactly this topic. So it's there. So again, there's no evidence. They're talking about anecdotes. They're talking about one-odd cases where they managed to treat it across man. But however, the important thing is these patients have got a very poor prognosis when they recur post-transplant. So most of them die from their disease progression, HCC. So whatever we can do to try and control the disease would improve their prognosis. Whether it is going to be your immunotherapy or which is not yet, or other modalities which is currently what we offer. It is tangled.
Immunotherapy means treat with immunotherapy. Immunotherapy is the only option left with for these patients, and if you don't treat, 100% mortality. So rejection can occur at least in 1/3 of patients, but not all of them will die. So it is better to go ahead with immunotherapy in the post-transplant recurrence scenario rather than wait and response.
The post-transplant recurrence scenario can happen in 2 different scenarios. One is, I mean, usually what we see is it happens within a year, most of them. If it happens within a year, the 2-3 papers published as of now have said a big no to immunotherapy. because the rejection rate, necrosis rate is very high. But however, having being said that, suppose if there is a recurrence after 2 years, where we say that liver is the only organ where the chimerism happens and it becomes stabilized, we'll be able to put them on a monotherapy. So after 2 years, if there is a recurrence, is it okay to use immunotherapy? I mean, it's all futuristic, but there are a couple of papers and trials are going on.
So there is a difference, I think, in post-HCC transplant recurrence which can be treated to some extent with surgery combined with systemic therapy. So I think immunotherapy is not the only option in this patient. We published it in Patoma research last year. 100 patients with recurrence, out of which in 60 patients, we could use a combination therapy of surgical resection along with systemic therapy. And the outcomes in those patients were much better as compared to systemic therapy alone. But again, the question comes, how many of them actually are where surgical resection is possible? So this surgical resection includes VATS, includes recurrence in the liver, it includes recurrence in the scar. So, even after recurrence, you should not give up. Exactly. If there is something that is resectable in combination with systemic. So I don't think that immunotherapy is the only option for that. I think that we have to think of surgical modality combined with systemic therapy. And if we can achieve it, we can prolong their survival. Of course, their outcome will be distant. Everyone is not going to survive for 5 years, 10 years, but we can prolong their survival by using a combination. And yes, maybe future will show us that it also can be along with that. And we've also switched them over to mTORI. So if you see the curves, in those where mTORI plus surgical resection plus systemic therapy, sorafenib, because this was 2 years back, was better as compared to using lenvatinib or sorafenib plus mTOR inhibitors alone, and was better as compared to sorafenib. So there was some use in with mTOR inhibitors as well. So mTOR plus systemic plus surgical resection is the best.
So again, multimodality approach. Because in cancer, even survival for 2-3 months makes a huge difference. So is there any ideal agent? We have PD-1, PD-L1 and CTL4 as of now. Because every other paper in oncology, one agent is better or it's equal or it's all the same or none works.
I think we just a little bit because we're still not sure whether another big state. So we're not able to discuss whether it's PD-1 or anything else. I'm very mindful of the time.
That's why
So perhaps
so again, ideal agent, I think as of now, there is no single particular agent which can claim that, one is better than the other. And timing, I think we discussed shortly. I mean, there should, suppose if the response is good after immunotherapy, and if somebody is thinking of transplant, at least give a 3 months time. It does 2 purposes. 1, it acts as a test of time to see the tumor biology and nature. And 2, it also gives a good period for the graft to survive post-transplant. And immunotherapy should always be the last resort, isn't it? Because of the adverse effects post-transplant. So like we said, the PD-1 is pembrolizumab and nivolumab. A lot of trials have come out. And PD-L1 is atezolizumab and durvalumab. This durvalumab, I think, is still in phase 1, clinical phase 1 and phase 2. And again, there are certain studies which are claiming that CTLA4 ipilimumab or tremelimumab is better than PD-L1. But again, like I said, there are enough papers to say both are equal as well. This I'm touching upon so that we're all familiar with the current immunotherapy available. Anything less harmful? So now people are moving into, the research is particularly focusing about NK cell infusions from the donor liver. I think that should be the futuristic thing, Dr. Prashanth. You were.
I know that there is one center that's working on it. I think you have one of these just showed you everything.
So the whole cancer is about NK cell failure. So nowadays, what people are doing is once the liver is perfused, the donor liver. From the perfusate, they culture the natural killer cells of the donor, and then they give an infusions post-transplant so that it takes care of the tumor microenvironment. And another interesting thing that's coming up is the CAR-T therapy. I mean, CAR-T right now is doing wonders for lymphomas and leukemias. And another research which they're trying to do is combine an NK cell along with the CAR-T, that is called NKG2D based CAR-T, CAR-NK cells, which will be available, and it is safer than immunotherapy to take care of the tumor environment so that it prevents recurrence. It's all hypothetical, but I mean, if we talk about this, maybe after 5-10 years, it can be into practice just for awareness. And phase 1 clinical trial of NK cells, Dr. Andrew Zakis has done in Miami, and now Stanford has taken the phase 2 trial. Futuristic, again, there's something called exosomes. Again, it's a very interesting thing. Exosome is available, will be available in the form of pills. Again, it takes care of tumor microenvironment and also impacts proliferating and progression of the cancer cells. So this people are trying to co-culture it with NK cells. This only the thought process has been put into. I mean, they've got the clinical approval for it. The trial is yet to start in Cleveland Clinic, and so they call it as happy medium pill, which are pro-inflammatory. So it's exosome is a mirror image of a cell, except that they don't have a nucleus. And if they co-culture with NK cell, it proves to be effective in preventing and taking care of tumor microenvironment. In futuristically, probably it can have a huge impact on the disease-free survival. And currently, exosomes are being used in GBM and pancreatic cancer. And soon we hope that for hepatocellular carcinoma also we're going to get it. So we'll end. It's already too late. Questions? Online.
You're the president.
Any questions online? Is there any question?
Are they still there? Sorry, 9:30.
Thank you very much, Charles. Thanks for organizing this. It's a long time. So, yeah.
So, on behalf of NKR Pharmaceuticals, first of all, thanks to Dr. Charles and Dr. Matthew, sir, for giving us this opportunity to organize this meeting. I think this is the first physical meeting in Cochin after COVID. And I think we at NKR, we are not only involved in terms of bringing innovative and affordable medicines, but many other such scientific things which will be bringing in future. So thanks to all for making for the evening, and let's open for the realization what is available. Thanks. Thanks.
Recording stopped.